Bismillahirrahmanirrahim. I'm going to take you in the next few minutes about the delirium to move it through the biomarkers. Thank you very much for inviting me to this conference. There is two eminent chairpersons for Syria and Arabic to allow me to give these minutes. Well, delirium actually is the borderline between psychiatry and medicine in general. We know that after operation in elderly people, they get what we call delirium. And the patient sometimes is jumping out of bed. My voice is not clear or okay. This is okay? Yes. Very loud. Let us, by definition, we know that this delirium is some sort of problem in the consciousness. In the consciousness, we are dividing it into quantity and quality. Quantity, that means he is going to be drowsy and in coma and so on. But sometimes in the delirium, the quality of conscious is not clear. The patient is conscious, but he is really stirring around, he has some sort of visual hallucination and so on. There's a lot of etiologies for this delirium. Actually, at the present, we know that the diagnosis depends on the clinical situation. But the question is there any biomarkers can help me to diagnose delirium? The last six approaches, this is a concentration of this talk. How can we reach the diagnosis of delirium by this approach? First, we have to go to serum chemistry, genes, neurotransmitters, inflammatory factors, serum cholesterol level, and finally the end product of delirium. As we know that the test of delirium is disturbance of the conscious, as I told you. If there is some sort of abnormal attention, agitation, and there is some sort of impaired cognition in the orientation, memory, thought, and so on. It is acute onset and fluctuating in the course. Sometimes in the morning he is demented, or there is some sort of delirium, and in the evening he can be like always. By the way, delirium is increased in the night. There is precipitating factors by acute medical illness, post-operative status, infections, and substance intoxication. There is some sort of behavior just more confused. Sometimes there is poor attention and looks around the room, is agitated, he would like to jump out and take off his clothes, is hallucinating, especially visual hallucination. Very quiet or drowsy, and this is very, very dangerous because we have two forms of delirium. One of them is hyperactive, is jumping out of bed, and the other one is hypoactive, which keep in cold corner, not moving, and sometimes we are feeling that he is really delirium or depression. There is reduced ability to care for himself, and there is a loss of mobility. Is it common delirium? Of course. Its prevalence in the community is around 1 to 2%. In the general hospital admission, it's more than 20%. On admission, it can be in the elderly 10 to 15% to the hospital. During hospitalization, it increased up to 40%. And at the end of life, it's up to 80%. So in the community, there is a percentage increasing in the admission, post-operative is increasing, and definitely in the ICU, it reached up to 80% of persons. As I told you, there is hypoactive, which is very common. Hyperactive, this is 1.6%, and the mixed delirium is around 54%. This hyperactive is better recognized because the patient would like to jump. It has more attention to the treatment and associated with improved outcome. In the hypoactive, It's little recognized. Depression is a primary differential diagnosis for this person, and it's associated with poor outcome. Definitely, there is a mixed bag. What about the causes of delirium? Sometimes this delirium is iatrogenic because this is due to the medication you are using. We know that delirium is due to cholinergic failure. So if you are using anticholinergic drugs with a high dose, you can or you may introduce delirium to the patient. Brain's way of demonstrating is acute organ dysfunction. How to figure out the trigger by the delirium? Could be from drug use, like hypnotic or anticholinergic. Could be from electrolyte imbalance, which is 40%. Could be to the lack of drugs, like withdrawal of alcohol, for example. Could be from infection, which is 40%. Could be from reduced sensory input. And this is really, it happens very frequently in the ICU. Sometimes in the ICU, the people there, they didn't see the daylight. So they didn't know which is day and which is night. That's why there is alternation in their sleep pattern, as Dr. was done. There is intracranial problem, like stroke, urinary retention or fecal impaction, and finally, myocardial or metabolic problems. In the iatrogenic, as I told, there is anticholinergic medications. If you are using opioids, benzodiazepine, steroids, antihistaminic, even antibiotics can make delirium. It could happen due to direct injury to the neurons, like metabolic and ischemia, and also altered senses release of the neurotransmitters, or it can be indirectly through the stress response, like in case of trauma, surgery, infection. All this will release what we call pro-inflammatory cytokines, and by this way it can make delirium. And these cytokines, after a while, we are going to measure it to know if the patient has delirium or not. In the neurobiology, it's best established by neurotransmitter dysfunction, especially reduced cholinergic activity. Increased dopamine may play a role in this delirium. Definitely, low or excessive serotonin, which is called serotonin syndrome, could you make a delirium. Also, low or excessive gamma. So we know that delirium is a clinical diagnosis. It depends on history and physical examination. We can detect this one by mental state examination, and there is a rating scale like confusion assessment method, delirium rating scale, and the clock test. If you would like to diagnose delirium, we go to the lab to ask for CBC, ESR, RBS, creatinine, urine toxins. We can also check for the X-ray, ECG, and other function if it is indicated, like in case of fever, for example. Neuroimaging and the EEG is very helpful because we know that the generalized slowness of the delirium, it's non-specific, definitely. But if you find what we call triphasic delta waves, that means there is some sort of hepatic encephalopathy. Also, there is low voltage fast activity in the case of benzodiazepine withdrawal. So in the lab, we are looking for the basic TSH, B12, liver function test, albumin. There is infection workup, and at the end, there is some percentage which cannot be reached. We don't know the cause of the delirium, which can be up to 15 to 25%. Well, it's very important to differentiate delirium from dementia, especially in the elderly, psychotic disorders like schizophrenia, mood disorders like depression and mania, and catatonia, because the patient sometimes is sitting doing no movement at all. The patient risk factors depends on the age. I mean, if it is more than 65, if he has kidney or liver disease, sensory impairment, dementia, polypharmacy, and physical disability. Finally, there is top independent risk factors, which are vision impairment, any severe illness, cognitive impairment, and high urea creatinine ratio. If we go now to the biomarkers, what are the biomarkers? It is biochemical or molecular parameters associated with the presence and or severity of the specific disease. And these are measurable. We can measure this one. We have three patterns of biomarkers. There is biomarkers telling you, take care, delirium is coming after a while. So these biomarkers detect you or let you know that the delirium is coming. Another one, biomarkers telling actually there is delirium. So it rises if the delirium is there and it's going down if the delirium disappears. Okay? The third one is telling you the delirium is over, is clear now. And there is some examples like that. If it is coming before the disease, it's something like lipoprotein epsilon 4. This is, if you find, that means this patient has already liability for dementia. So that means in case that you give anesthesia, he will develop delirium. The other one is something like the ovarian cancer. So if the ovarian cancer is improved, this biomarker is going down. Finally, in the end product, we can see this one in the myocardial infarction. After the infarction disappeared, the creatinine kinase disappeared from the blood. Actually, this is the main biomarkers for delirium. There are 6. Serum chemistry, genes, neurotransmitters, inflammation, chronic stress, and finally the end product of the delirium. I'm going just to give only one slide for each one. In the serum chemistry, there is some sort of ratio between the nitrogen and creatinine. If it is over 18, that means this patient has really delirium. Also, the abnormal serum level of sodium, potassium, and glucose. And finally, the low albumin and hypermagnesemia, this can be definitely increase the risk of delirium. Next one is the genetic. As I told you, the apolipoprotein epsilon 4 alike, that means this patient has liability to get dementia or Alzheimer later on. So he has what we call genetic risk markers. This alike increase the risk of post-operative delirium after non-cardiac surgery. Also in the genetic, we have 2 what we call genes responsible for the dopamine. One of them is called dopamine receptor, and the other one is called dopamine transport genes. These 2 genes, if they are there, and there is some sort of polymorphism, this reduces the risk of delirium. If we go to the neurotransmitters, the most important one is acetylcholine, because we know that delirium means cholinergic failure. So if we are using a lot of anticholinergic drugs, it will make toxicity and delirium. These neurotransmitters can be measured in the blood by using radioreceptor assay. And this is really a very important biomarker for delirium. The neurotransmitters, another one, serotonin, melatonin, and serum amino acid. Regarding the serotonin, as you know, it depends on the tryptophan and the availability of this one in the blood itself. So it depends on this tryptophan is competing with the other large amino acids to go through the blood-brain barrier. So if we are measuring this one in the blood, and we see the plasma ratio between tryptophan and large neural amino acids, this means there is indirect peripheral measure of central serotonergic function. Both increase and decrease of the serotonin activity are associated with delirium, and this will happen mainly in what we call hepatic encephalopathy. The second one is called melatonin. You know that melatonin is responsible for the sleep. It depends on the character, duration, and the quality of sleep. So, if this happens, the sleep will be disturbed. There is no post over pre-operative. They are measuring the melatonin pre-operative. After operation, they are measuring the melatonin again. If it is lower than pre, the patient will be insomnia. If it is higher than the pre-operative, the patient will go into deep sleep. And this was measured by the metabolic of the melatonin, which is called 6-sulfur-deoxymelatonin. The serum amino acid also, there is no actual research for the last 15 years about this one, but it is fluctuating wildly. And that's why there is analysis using amino acids require special processing of the serum. C-reactive protein, actually we are using this one widely in our lab because it depends, it means there is some sort of inflammation in the body. This is associated with vascular endothelial cells. Actually, the higher level of C-reactive protein were seen in post-operative elderly with complications. The cytokines and chemokines, this is inflammatory markers, and this is used as a marker for delirium as well. Cytokines, as you know, it's activated immune cells. But the chemokines, it's a local cytokines inviting the white blood cells to come to the site of inflammation. There is therapeutic use of cytokines, which is interferon, and they found that interleukin-1 is increasing acetylcholine esterase activity. Interleukin-6 and delirium, there is definitely association between both of them. The cholesterol, definitely, it depends on the stress. And when the stress coming, the cortisol level is increasing, and this is denote that there is hypothalamic pituitary adrenal system is activated. Finally, this is the number 6. This is the end products of delirium. There is two things. One of them is protein called S100P. And this is coming from the astrocytes. It depends, this one, on the integrity between astrocytes and Schwann cells membrane. And this is a strong, independent biomarker for delirium. And the other one of the end product is called enolase. This neuron-specific enolase is circulating in the blood, and we can measure it, definitely using special machines. Now, we finished the markers. We just let you know that to overcome the delirium, we should sometimes use non-pharmacological tools, and the patient are dangerous from them or other. That's why you have to work. We know quite well that if we ask for a psychiatrist in a general hospital like licensed psychiatry to come to see the patient in delirium, he's using low dose of haloperidol, risperidone, olanzapine, but you should avoid use of benzodiazepine. So neuroleptic is the level 1 to use this therapy. We have to know that the dose should be PM because delirium is increasing in the evening. And medication must be discontinued immediately after the delirium is go away. To prevent delirium, we have to look for the cause, encourage good nutrition, correct sensory deprivation, encourage sleep, normal sleep, and promote cognitive. The prognosis is usually reversible. If it takes several weeks of mental function to go to the normal. Longer the delirium, that means it's bad prognosis. The pathogenesis efflux, there is inflammation, neural apoptosis, and brain atrophy. This is outcome. We have to know that after all this one, the mortality is around 1/3 of cases in elderly. In conclusion, dementia is a risk factor for delirium. We have to recognize delirium and distinguish this syndrome from psychiatric conditions like depression. Delirium can present a variety of ways, and because it has a lot of etiologies, the biomarkers of delirium are the 6 serum chemistry, genes, neurotransmitters, inflammatory factors, serum cholesterol, and end products of delirium. Antipsychotic medication are useful in the management of symptoms of delirium. Thank you very much.